Welcome to the Culinary Medicine Interest Group podcast. With us today, we have Dr. Ranjan back again, this time to talk with us about hypertension. So I'm going
Hi,
to start
John.
off just by introducing the problem, if you will, that in the United States, hypertension is one of the most common health issues that most adults face. I think the number is up at around a third of U.S. adults are living with some form of hypertension, and a lot of it is related to the Western diet that we kind of follow as a country and related to the excess sodium present from all the processed foods and the style of cooking that we have. So I wanted to ask Dr. Ranjan, we know from our culinary medicine curriculum that the dietary approach to stop hypertension, or the DASH diet for short, is widely recommended for managing dietary sodium through fruits, vegetables, and whole grains. And is this something that you see commonly mentioned in practice, either by yourself or your colleagues?
Yeah, I think we all definitely focus a lot on the DASH diet because I'll be honest, almost everyone I'm seeing in my practice in the office does have hypertension. A lot of my patients also have congestive heart failure. So we spend a lot of time talking about, how much sodium they should be having. In general, I tell them to stick to less than about 2 grams of sodium. So yeah, we definitely discuss it extensively, both in the office and in the inpatient setting when we see our patients.
Do you think there are any barriers surrounding the implementation of the DASH diet or with patient compliance?
So, I think what we don't, at least I didn't realize until I started practicing, was it's very easy to tell someone to stick to having less than 2 grams of sodium a day. But the barrier really is that a lot of people don't cook their own food. And a lot of the poor patients that we take care of, they live in food deserts. And so they don't actually have money to cook their own food, and they don't have access to fresh fruits and vegetables. And so a lot of them do end up relying on fast food or canned foods and processed foods. And over and above that, they don't have enough awareness to realize how much sodium they're consuming when they're having this. So I think first and foremost, it's hard to address the food desert issue just as a physician, and that has to be something we're addressing as a society. And a lot of people are working towards doing that. But I think when we see our patients in the office, what I try to tell them is, to the extent that it's possible, try to cook your own food so that you know exactly what you're adding to it. Try to stay away from ordering out if you can. And if they are consuming canned foods or processed foods they're buying at a market, then I try to teach them to make sure that they're going through the label and they're really adding up, how many milligrams of sodium there is per product. They're even when they're looking at simple things like packets of potato chips, there's a difference between the amount of sodium that there is in a packet of potato chips, and you just have to teach them to look at the label very carefully. And then, of course, there are certain people where it's not so much on account of food being expensive, but they've been used to a certain cuisine their whole lives. And it just takes, behavioral change is hard to bring about. So it just takes emphasizing again and again the importance of cutting down that sodium level in order to prevent, their blood pressure from getting worse, from them having heart failure, exacerbations, et cetera. So I think that's the other aspect of this, is just bringing about behavioral change. But yeah, I think those are the two main barriers, or 3 main barriers: access, literacy, and behavioral change.
Thank you. You bring up a lot of interesting points there. I know something that we've been working on as an interest group through some of our outreach is trying to develop some healthier, shelf-stable alternatives for places like food pantries that you may have more access to foods that are processed or canned, and kind of helping to build the literacy of how much goes into those products in terms of sodium. And you also brought up a couple of other questions that I wanted to ask. Aside from, you mentioned canned foods and processed foods, are there any other like hidden sources of sodium or high sodium that your patients you find often overlook? And also, when you're recommending cooking at home, are there any strategies that you recommend in terms of things like seasonings, herbs, and spices to try to substitute out sodium so that you can still end up with a flavorful dish without necessarily having to turn to that salt shaker?
There being a lot of sodium in soup and canned foods, anything with preservatives, pickles, anything that I just tell them anything that's preserved and salty, just be careful. Anything that's dried meats, dried fish. I can't think of, other than that, what would have a large amount of hidden sodium in it. But the strategies I do tell them is I tell them to focus on simple things like you can use salt-free Italian seasoning. You can use Mrs. Dash seasoning. Foods that are heavy in tomatoes, because tomato tends to add a lot of flavor. So those are the general strategies I think I tell them to do. Mrs. Dash is usually the most popular one, I would say.
Just for our listeners who might not know what that is, what is Mrs. Dash?
Oh, Mrs. Dash seasoning is basically you get a salt-free seasoning. I'm trying to see if I can pull up exactly what it is, but basically it's just a salt-free seasoning, and you can add it on practically anything. You can add it on vegetables. It's a blend of different spices, and it just adds a lot more flavor. So for people that I that feel like they need to add salt to their food, I try to ask them to substitute it with this seasoning. It's something that you can buy basically anywhere on Amazon, Walmart.
Very cool. We love giving patients strategies to make their food taste delicious and still, nourish them appropriately.
Yep.
So I want to transition a little bit to potassium. We've studied how the increased intake of potassium can help to balance out sodium excretion. And in the Western diet, potassium is often underconsumed. So do you ever use dietary potassium as a target for hypertension mitigation? And if so, what strategies do you use?
Right. So I don't use what their serum potassium levels are as such in terms of monitoring their blood pressure control. I really just focus on what their blood pressure is in the office, and more importantly, what ambulatory blood pressure readings are at home, because that's far more important than their blood pressure in the office. But what the guidelines do tell us, and you guys are absolutely right, that increased intake of potassium will balance out sodium excretion, and that in general, the Western diet, we tend to consume far less potassium than we should be. And so if you look at the hypertension guidelines, whether you're looking at the American guidelines or the World Health Organization guidelines, it is recommended that you hit approximately somewhere between 3,500 to 5,000 milligrams of potassium per day. Now, again, I tend to not ask my patients to maintain a potassium diary like I would, let's say, with blood pressure or with sodium, because really the way that you make sure that you have a diet rich in potassium is, again, just having a lot of fruits and vegetables. So if you're having 4 to 5 servings of fruits and vegetables, then you'll get to approximately 3,000 milligrams of potassium. So again, I try to keep it as simple as possible. So if they're measuring their blood pressure every day and they're keeping a blood pressure log, and they're keeping sort of a nutrition diary, then that's usually enough. I'll really just check their potassium to see how they're doing, if they're on medications, or I'll check it once a year. But I don't usually use a serum potassium level as a target. And I think that would become too tedious. And really, it's not. That's not what the recommendation is. It is about making sure that they're just consuming enough of it in a day.
Thank you. I think that's a really good point, that adding another thing for the patient to track on their own can be a little bit tedious and make it more difficult for them to follow. And you brought up another point about medication, and that's something that we did want to ask you about as well, in terms of just how can one's diet affect the medications that they may be prescribed for their hypertension if they are on medication, and just sort of interactions that you may notice between diet and specific medication regimens for hypertension.
So, the most important thing that I think of, or the most important consideration is, are they on certain antihypertensives, which will result in an increased potassium level, especially ACE inhibitors, angiotensin receptor blockers, spironolactone, because all of those result in high potassium levels, whereas the loop diuretics like chlorothalidone, hydrochlorothiazide, et cetera, will result in a reduction in potassium. So if they're on any of these medications, and you guys will see this in practice, especially if they're on loop diuretics and their potassium tends to run low, oftentimes we have to supplement them with potassium because they're not getting enough through their diet. And so those patients are the ones that initially I'll try to see if I can just tell them to have a large amount of fruits rich in potassium, banana being the most common, but also just oranges and melons, honeydew melon or spinach. All of that will result in an increase in your potassium level. So if you're already taking medications that result in a drop in that, I will tell them to make sure they're having a couple of bananas, in addition to considering whether or not we need to supplement them with potassium supplements. The other, and if vice versa, if they're taking medications that actually raise their potassium levels. The other thing is we end up taking care of a lot of patients that have chronic kidney disease. And so you really want to be careful about the potassium level in those patients. And so in those patients, you really want to tell them to avoid foods that are rich in potassium. But, hypertension and chronic kidney disease often go hand in hand. So that's a patient population you really want to focus on diet to a greater extent. And in general, anyone that's on an antihypertensive, I go over dietary measures, which includes keeping the sodium low, because that in and of itself will result in a reduction in blood pressure. And you kind of want to couple that with the antihypertensive, because you don't want to have to keep going up on the dose of an antihypertensive when they could have just coupled it with lifestyle measures and kept stay on a lower dose instead. So I think sodium and potassium and foods that impact those two are what I would focus on.
Thank you for that. I think we would really agree with you that a combination of pharmaceutical and lifestyle modifications are the best way to approach really anything. Do you find that when you prescribe antihypertensives, your patients' appetites are affected? Do they experience any cravings or weight loss or weight gain?
Yeah, that's a really interesting question, but I will be honest. I haven't had anyone. A lot of antihypertensives have other side effects, but weight gain and cravings have not been. No one's told me that it's impacted their appetite or cravings or weight gain. So I would say fatigue and lack of energy is something a lot of patients experience with beta blockers, but it resolves on its own, I would say, within the first couple of weeks. And as you guys know, we don't typically use beta blockers as our first-line antihypertensives anymore. So we're only prescribing it in patients that, let's say, they have had a myocardial infarction or have congestive heart failure with a reduction in their LV systolic function. And so in those patients, especially, I think there were reports with metoprolol where patients do tend to gain weight, but I think it's mainly because it results in a little bit of a lack of energy and fatigue, and they say they feel slower than before. But again, usually they're very well tolerated, and that resolves within a period of time. Their body gets used to it. And when we're giving somebody a beta blocker, it's almost always because they've had an event that requires them to be on it. But otherwise, I wouldn't say I've had anyone tell me that it's impacted their appetite or cravings. The other common side effect is with amlodipine, patients tend to have some ankle edema, but they don't really come back and say that there's weight gain. They'll specifically point to swelling of the ankles. I can't think of anything else.
Thank you. We know that from our studies that there's just a whole host of different antihypertensives. So it's important for us to kind of understand the greater picture of how they impact patient lives and the different things that patients may come in and tell us after being started on any of these different medications. So I think to close out, I know we've only really scratched the surface of hypertension and how it's very intimate relationship with diet, but I did want to ask you, if you had to give us one low sodium dish, what would you choose, and kind of describe it to us?
No, so I thought about this a lot. It's pretty easy, I think, to choose a low sodium dish. I would say I think a lot of salads can be made without excessive salt, etc. But I would say I like stews in general, especially in the winter. So I don't know if you guys have heard of Alison Roman's famous chickpea stew that was it was an internet sensation last year, but that's one of my You just made
I
it.
just made it yesterday. Yeah.
Yeah, no, that's it's one of my favorite winter stews around this time of the year. I always make it. It's a chickpea stew with coconut milk and turmeric. And you can actually make it without a lot of salt because a lot of the flavor comes from the coconut milk and the turmeric. So I would say that's probably one of my favorite low sodium dishes.
And I think that's a great suggestion too, because it uses canned chickpeas. And so it's just like a great way to teach patients that you don't have to eliminate things. You just have to learn how to use the ingredients.
Yep, exactly. That is what I tell my patients every day. It's very, I'm not a big, as I said this before, I'm not a believer in the all or nothing mindset. So it's just about tweaking what we can to get the best results.
Thank you. I think that's an excellent way to conclude our talk. Everything in moderation and learning how to make small incremental changes can go a really long way for patients. All right. Thank you very much, Dr. Ranjan, for your time and spending your time speaking with us twice on 2 podcasts. So thank you very much.
No problem, guys. Thanks for having me. This is a lot of fun, and I think it's a great initiative.